Next speaker we have is Petros. He is from Cyprus and he is going to start with one of the very minimally invasive surgical options available. We are going to start from the mist to the mega surgeries. Yes, Petros.
Thank you, Ananda. Actually, it's a very good timing to follow on Hasim's presentation on how to evaluate the patients. Let me just, sorry if I can. I will have a very brief presentation on the UroLift, which is the minimal invasive treatment for BPE, as we put it. We will try to put some of the details mentioned in Hasim's presentation, which is a must for every clinic into practice. These are my disclosures. So the UroLift is, well, the way, if we can use a metaphor, is nothing more than a glorified stapler. But it takes some skills to be able to implant the, to insert the implants in the right places in the prostate, securing an anteromedial channel, because you don't get a second chance. Most of the other modalities, you can go back and amend any sort of mistakes. So with the UroLift, given that it's very minimally invasive and you basically, it's a day case without the use of catheter, the people can be ambulatory and go home the same day. It requires some skills. This is the device. It comes with the scope of its own, 19 to 20 French. This is the gun, as I call it. And it has a handle. The blue handle is the one that releases, deploys the capsular tab made of nitinol, which is a combination of titanium and nickel. Then there's a polyethylene absorbable stitch that will be revealed as following the blue trigger, you press the gray, and then by the simultaneous move medially and proximally towards the bladder neck, you start seeing the capsular tab, which is made of stainless steel. And that's when, by using the little handle here at the back, you cut the stitch over there and you release it free in the prostatic urethra. The angle, this is the device. It comes, it's provided, the scopes are provided by the manufacturer. And at the moment, the way things are, you're using a single gun for a single implant. On average, mentioning the guidelines, you use about 4 for an average sized prostate. In our series, we use 3 for some reason. So this is the implant compared to a human hand, just to give you an idea of how small it is, regardless of how gigantic it looks in the cystoscope. And that's the actual procedure with the lithotomy position placed with the patient. As we mentioned before, by pressing the blue trigger, it releases the capsular tab, the nitinol based. You have to use an angle of about 15 to 20, well, maybe 20 to 25 degrees. And you have to place the capsular tab, which is the most important one, in a specific angle. So it has a shape memory capability. So it adapts and finds its place to the capsule. The rest is followed by the stitch. As you press the gray trigger after the blue, releases the stitch. And then by using your thumb, it releases the implant altogether in the urethra free. Now, we can have different surgical techniques on how to use it. Being ambidextrous is recommended, but we're not going to hold it against you if you're just using one hand for either side. Again, very briefly, these are the steps. As you're going in the urethra, you assess with a scope, and then you place, starting from the proximal side, you place one on each side. It's not used like the resume, for example, but you have to deal with one lobe first and then move to the other. You work on either side first and start working proximal to distal. Of course, as your experience gets bigger and your confidence gets higher, then you can use techniques of your own, you can improvise, but to start with, and when offering procedures on general anesthetic, this is what is recommended, proximal distal. This is a cystoscopic photograph of very familiar, we are very familiar, all of us, with it. A view of the prostatic segment from the verumontanum before the treatment with UroLift, and this is after. As you can see, a successful treatment is considered when at the end of it you can see the bladder neck being open, and hopefully that will secure a good free flow. The small indentations that you can see on the other side of either side of the lobe is obviously the spitzes pulling it back. This is not a very big prostate. It looked like two of them did the job in this case. The guidelines, they certainly recommend the UroLift as an alternative treatment now. They are being updated constantly. They are being, even the UroLift device treatment is considered as a first option, as a primary treatment, even before medication coming from NICE. It's something that certainly younger people who want to preserve sexual function, like the ones we see, for example, with me having a special interest in andrology, is certainly a very important weapon in our quiver. The EAU guidelines, they recommend the treatment following, of course, the tests that is mentioned in the clinic, which is can be a very well one-stop clinic, as we have instituted in 5. They've been more conservative to start with, so they recommend no bigger than 70 mils size prostate, and as we mentioned, is definitely recommended for people who want to preserve their ejaculatory function. So far, studies have demonstrated that is preserved. The NICE guidelines, they are more bold. They say that you can go up to 100 mils if you want to, without an obstructing lobe. Coming from my experience, of course, other speakers may disagree, but it does seem to be much more favorable if there is no presence of a huge lobe. There are some tricks that it's not for the present time to mention when you're doing the cystoscopy, how to get yourself away from traps and over-treating the bladder neck, which is something that we do not want. NICE guidelines gave an age limit as well of 50 years or older. And the AUA guidelines, again, mentioning that is a surgical, minimally invasive surgical treatment that can certainly be considered, especially for people who are very keen on preserving ejaculatory function and very conscious of their erectile function as well. This is the data so far. As you can see, as years go by, there's more and more cumulative knowledge on this technology. It's quite a couple of randomized studies, but as you can see, we're talking about almost 100,000 patients treated and almost 500,000 implants delivered. So it looks like there's a lot of centers in the UK that offer the service now, even under local anesthetic, as a one-stop ambulatory setting, and it's gaining more and more ground as years go by. This is the study from Prof. Weber in Texas, which was it was the giant, the shoulders on which I stood up when I set up the service in 5. It's called the LIFT study. They presented 5-year results. They have been updating the data as they were collecting it. And what these showed from 19 centers in North America and Australia is the durability, as you can see, of the results. For 5 years, the IPSS, after decreasing initially following treatment, basically it remains stable along the time of the period that the study was run. This is the UroLift compared to other minimally invasive treatments and the so-called gold standard TURP, which I disagree. I don't think TURP should be called a gold standard anymore. And as you can see, retreatment rates are certainly comparable. Again, some more data. As you can see, again, the so-called TURP compared to a gold standard treatment compared to the UroLift. And when it comes to the first even month of the treatment, there's a rapid alleviation of the symptoms. And as the months go by, this study is for 12 months, they remain the same. So following a very rapid alleviation, improvement of symptoms, then following the curves, you see that they end up basically in the same point. So patients feel much better, much sooner. Now we're moving on a little bit away from the clinical trial, which are making very controlled. There's some studies that were run into a so-called real world, and there were almost 1,400 cases recorded. And on those, there were people included with retention and IPSS and AIDS, but they were way a little bit above and beyond the very confined and airtight limits of a study. And again, in this 2-year data collection that is demonstrated here, the IPSS score in all patient groups, those who had a baseline retention, urinary retention or not, were the same, as you can see. Now, what happens with retention, which is one of the main questions? Of course, that was one study. They showed in this non-clinical setting that, in a clinical trial that it can work, but this Hansen Blue, there, Olli Case and the team, they concentrate specifically on the acute urinary retention patients, and they are receiving a treatment of UroLift after having failed TWOX. The study is called PULSAR, and they have presented the data, which was certainly very encouraging. Basically, this patient selection were, in terms of prostate size and age, are not big surprises, about 100 grams, 50 years old. But the difference now was more than one failed TWOC and being on oral medication. The primary assessment was trying to take the catheter out in about 3 days after delivering the UroLift implants, and again with a history of retention, and following them up with questionnaires and maximum flow measurements afterward. Basically, as you can see, age-wise and prostate size-wise, they went further, higher and beyond the previous studies. And what they have showed is that 67%, there it is, 67% of the patients were catheter-free by 1 month, and 79, almost 80% of them by 3 months, again, with a history of retention. Of course, they did have treatments. Down there, they had 3 patients, they received other modalities, and 2 of them had a repeat of the UroLift. I will just go sail through safety features of the UroLift. Very good question, of course. As Hassan mentioned before, people who want to have either before or after, they have a history of prostate cancer in the family, or they want to be followed up for prostate cancer in the future. How does UroLift come into this equation? This is an MRI image of the implants, showing, of course, the urethral tract there. It has been investigated, and it's, more data is collected as we moving on. Basically, the conclusion was that the UroLift artifact, the implant artifacts, are not interfering with the areas where suspicions of cancer are raised. There is an MRI PUL study that has been found in the literature, and that demonstrates exactly what we said, basically, that there is no artifact on MRI that can affect basically our clinical judgment once patient has received the implants and wishes to be investigated for cancer. Now, the MRI itself, apart from the images, the MRI itself is considered to be compatible, the UroLift rather, compatible to the MRI, up to 3 Teslas, which is more than enough to diagnose cancer. And the demonstration, the data that was found from studies showed that there was only a 2.4 degrees increase of the temperature of the implants after 15 minutes of imaging of the MRI, continuous imaging of the MRI, which was considered safe. So for both reasons, as we say our patients as well, it's certainly not the end of the line if you have UroLift for prostate cancer investigations. Of course, Prof. Redburn, as we said, moving on a little bit very quickly to the sexual function, they have demonstrated that certainly in follow-up, it can preserve sexual function, even for 2 months, for 2 years following UroLift treatment, the so-called MedLift study, they managed to demonstrate the same results even with the presence of a median lobe. Again, that will be subject to patients and surgeon discussion and the surgeon's views on the matter, and that is something that doesn't come under strict guidance at the moment. I will just finish with what we have been where we have been established in 5. This is Prof. McQueenie, which is the former president of BADS, which is very catchy for the British Association of Day Surgery. He visited 5 a couple of years ago, and what struck me was that what he said is, if you give the patients a bed, they will use it. So give them a chair instead. This is something unforgettable for me, because we did exactly that in 5. People don't need beds. You just give them a bed, they will use it and lie down. So if you have a quick turnout in a day stay unit, in a clinical setting, even under local anesthetic, why not use it? And what comes to mind more than the UroLift procedure? So this is another poster that I found in one of our lifts, adapted from Addenbrooke's, basically saying that you don't have to take your clothes off. Well, it was an exaggeration, you get treated, but there is some data there about loss of muscle mass, more than 10%, if you stay 1 week in bed rest. Obviously, that comes for different specialties, maybe geriatrics, but in essence, we do not want people to be in bed. This is our unit in 5. Left and right are consultation rooms. I will show you very briefly that it's also a treatment room. It's nothing more than half of the size of an outpatient department with this randomly posing nurse over there. This is the bay, which is first the admission bay and the recovery. 4 beds, and can be modified more if you wish. So as you can see, that all that it takes, we go in the morning, we see the patients, we consent them, and then we bring them to this room where we only use lightly chilled Instilla gel, which we save in a fridge since morning. We give about 20 minutes, and we just leave them to relax for a little while, and then we take them to this room, which we also use for flexes and urodynamics, and this is the treatment room. This is how easy it can be, and that's where we do the UroLift under local anesthetic. So after that, they're going back. This is the room with the staff being there. As you can see, the so-called scrub nurse is just using sterile gloves and an apron, and that's it. So it's totally transformed into an ambulatory case, and then they're going back to the same room where they are admitted, and moving on after a few hours after being admitted, moving on back home. Of course, with the main question being where they're going to go back to the golf course. So with this setting, we managed to move away from this theater here, where we started the UroLift and general anesthetic, to the clinic that I have shown. This is something that we're blowing our trumpet a little bit. It's been adapted by NICE, but yes, UroLift can be treated, BPO, as you call it, can be treated as an ambulatory, in an ambulatory setting, outpatient setting, under local anesthetic. We have a very big interest in simulation courses for BPH, but this is not something that we can expand at the moment. We're very happy to have trainees over there to train and put a hands-on on BPH treatments, and also it's been adapted very proudly by the University of Edinburgh, the minimally invasive treatments as a new section. This is the end of my presentation for now. Of course, there will be time for questions later. Thank you very much. Thank you, Anand.
Thank you, Petros. That's a fantastic presentation and setting the starting stones for the rest of the session. I'm very much interested with your concepts of doing the UroLift under local anesthesia and also the ambulatory settings. I think the day will come that your ambulatory unit may not need any beds and we can just have chairs. And
Yes, just chairs.
yeah, that's the future. Very nice.
Mhm.